Hello, everyone. Welcome to your lesson on the nervous system disorders. In the previous lesson, we explored the normal anatomy and physiology of the nervous system, including the brain, spinal cord, neurons, and how nerve impulses are transmitted. Understanding the normal function of the system provides the foundation for recognizing what happens when a disease or injury disrupts the system. Now, neurological disorders can affect virtually every aspect of a person's life. They may interfere with movement, sensation, memory, speech, coordination, vision, or even the body's ability to regulate breathing and heart rate. Some disorders develop suddenly, such as strokes or traumatic brain injuries, while others progress slowly over many years, such as Parkinson's disease or multiple sclerosis. Now, throughout this lecture, we're going to examine the underlying pathophysiology of common neurologic disorders and discuss how these produce the characteristic signs and symptoms that we see as nurses in our patients. Now, we're also going to review diagnostic tests and treatment options commonly used to manage these conditions. Now, as we move through each disorder, I highly encourage you to continually ask yourself two questions. What part of the nervous system is affected, and how does damage to that structure explain the patient's symptoms? This will help you develop strong critical thinking and clinical reasoning skills. This is the learning objective for this lecture. This is a brief outline of the disorders that we're going to talk about. We're going to start with acute neurologic problems. We're going to briefly cover congenital neurologic disorders because this is a topic that's covered in pediatrics. Then we're going to move on to seizure disorders and chronic degenerative disorders. Although these disorders have different causes, many share common neurological manifestations because they ultimately damage neurons or interfere with nerve conduction. Let's begin with brain tumors. So brain tumor is any abnormal growth of cells within the brain. They may be benign, meaning they do not invade the surrounding tissues, or malignant, meaning they are cancerous and infiltrate nearby brain tissue. However, unlike tumors in other parts of the body, even a benign tumor can become life-threatening because remember, the skull is a rigid structure and it cannot expand. So any additional mass inside the cranial cavity increases ICP. As this pressure rises, normal brain tissues become more compressed, reducing blood flow and oxygen delivery. Now, patients may develop headaches, nausea, vomiting, seizures, personality changes, or focal neurological deficits, depending on the tumor's location. Now, as the tumors continue to enlarge, they may obstruct the flow of CSF. This can cause hydrocephalus, or they may even compress vital brain structures. Tumors involving the brainstem are especially dangerous because remember, they can interfere with breathing and cardiovascular regulation, even when relatively small, right? So the key to remember is that brain tumors can cause problems in two ways. First, they can damage the specific area where they develop, producing focal neurological deficits, or they can increase ICP, which affects the entire brain. So let's take a closer look at brain tumors. This is a cheat sheet I created, so please go ahead and print it and use it as a reference. Now, primary brain tumors originate within the central nervous system itself. Examples include gliomas, astrocytomas, meningiomas, and pituitary adenomas. Secondary brain tumors are actually metastatic cancers that spread to the brain from other organs, and that is most commonly the lungs or the breast. Now, one feature that makes malignant tumors particularly difficult to treat is that they rarely have clear borders. So instead, they send microscopic projections into surrounding healthy tissue, making complete surgical removal very difficult. Patients commonly present with progressive headaches that are often worse in the morning because ICP naturally increases overnight while lying flat. Now, as the tumor enlarges, seizures frequently occur because of the irritated neurons begin firing abnormally. Now, personality changes, confusion, visual disturbances, speech problems, or weakness may also develop, depending on which region of the brain is affected. Diagnosis typically begins with MRI, which provides excellent visualization of the brain tissue. CT scans may also be used, especially in emergency situations, or a stereotactic biopsy confirms the tumor type and degree of malignancy. And treatment for this depends on the type, size, and location of the tumor. Surgery is usually the first option whenever possible, followed by radiation therapy to destroy remaining tumor cells. Chemotherapy may also be used, although a lot of these chemotherapy drugs have difficulty crossing the blood-brain barrier because remember, that's there to protect the brain, right? So it doesn't let things enter. And as future healthcare providers, it's really important to recognize warning signs of increased ICP in patients with brain tumors, worsening headaches, projectile vomiting, changes in level of consciousness, papilledema, and new neurological deficits. All of these require immediate evaluation because they could indicate rising ICP or impending brain herniation. That's when the brain tissue pushes against the skull. Next, we're going to discuss vascular disorders of the brain. Now, these disorders occur when blood flow to part of the brain is interrupted. Because neurons require continuing supply of oxygen and glucose, even a brief interruption in circulation can have severe consequences. And that's the reason why when patients are hypoglycemic, it's important to make sure to, fix that problem. Now, there are two major vascular disorders we're going to discuss: transient ischemic attacks, or TIAs, and cerebrovascular accidents, commonly called CVAs or strokes. Think of TIA as a warning sign. Blood flow is temporarily reduced, but the blockage resolves before permanent brain damage occurs. Although the symptoms may disappear, a TIA should never be ignored because it can significantly increase a patient's risk of having a future stroke. A stroke, on the other hand, occurs when blood flow is interrupted long enough to cause an irreversible death of brain tissue. Unlike many other tissues in the body, as we discussed in the previous lectures, neurons cannot regenerate once they die. That's why rapid recognition and treatment are so critical. One important concept to remember is that neurological deficits correspond to the area of the brain that loses its blood supply. For example, damage to the motor cortex produces weakness, while damage to the language centers causes speech difficulties. So understanding the brain's anatomy may help explain why stroke patients present with such different symptoms. A transient ischemic attack, or TIA, is often called a mini stroke, although that's somewhat misleading because no permanent damage really occurs. A TIA happens when blood flow, like we said, through a cerebral artery is temporarily reduced, usually because of a small clot or atherosclerotic plaque from all the fatty foods, burgers and french fries that taste so good, right? But they create plaque in our vessels, or temporary arterial spasm. Since the blockage resolves quickly, oxygen is restored before permanent injury happens. Now, patients often experience sudden weakness or numbness on one side of the body, temporary vision loss or blurred vision, difficulty speaking, dizziness, or facial drooping. The key difference between a TIA and a stroke is that symptoms completely resolve, usually within minutes and always within 24 hours. Even though patients recover, a TIA is a medical emergency. Studies show that the risk of a major stroke is the highest within the first few days of a TIA. Early evaluation allows us to identify the underlying cause and begin preventative treatment before permanent damage can happen. Now, treatment focuses on reducing future stroke risk by controlling blood pressure, diabetes, cholesterol, encouraging smoking cessation, and prescribing antiplatelet or anticoagulant medications when needed. Now, one important thing to remember is never ignore symptoms just because they improve. A TIA should always prompt immediate medical evaluation. Now let's discuss strokes. This is one of the leading causes of disability and death worldwide. A stroke occurs when blood flow to part of the brain is interrupted long enough to cause permanent neuronal death. Remember that brain cells begin dying within minutes of losing oxygen, making stroke one of the most time-sensitive emergencies in healthcare. There are two major types of stroke. The first is an ischemic stroke. This accounts for about 85% of all strokes. These occur when the artery becomes blocked by either a thrombus, which forms within the vessel, or an embolus, which travels from another location, often the heart. The second type is a hemorrhagic stroke. This occurs when cerebral vessel ruptures, causing bleeding into the brain tissue. These strokes often are associated with uncontrolled hypertension. And that's the reason why we should always educate our patients to manage their blood pressure. And usually they produce a more rapid increase in ICP, making them especially life-threatening. Now, one phrase you're going to hear frequently is time is brain. During an untreated ischemic stroke, approximately 1.9 million neurons die every minute. And remember, these are not going to regenerate. They don't go through mitosis, as we mentioned, right? Once they're dead, they're dead. So that's why recognizing stroke symptoms is extremely important. Now, one helpful tool you can use is the acronym FAST assessment. F stands for facial drooping, A stands for arm weakness, S stands for speech difficulty, and T stands for time to call 911 immediately. Now, the first hour after symptom onset is often called the golden hour because rapid treatment offers the greatest chance of saving threatened brain tissue. For eligible patients with an ischemic stroke, an IV TPA or tissue plasminogen activator can dissolve the clot if administered within approximately 4.5 hours after symptom onset. Now, some patients with large vessel occlusions may also benefit from mechanical thrombectomy. This is where specialists physically remove the clot using a catheter. In selected patients, this procedure may be performed up to 24 hours after the symptoms begin. Now, it's extremely important to distinguish ischemic from hemorrhagic stroke because treatments are completely different. Medications would medications that dissolve clots can save a patient with an ischemic stroke, but would dramatically worsen bleeding in a hemorrhagic patient. Because remember, in a hemorrhagic stroke, you have bleeding in the brain, increasing ICP. So you don't want them bleeding more. So this is why every suspected stroke patient receives an emergency CT scan before treatment begins. Now, long-term recovery often requires a multidisciplinary team, including physical, occupational, and speech therapists. This helps the patient regain as much function and independence as possible. Now, once again, as nurses, we need to remember time is right. Next, we're going to discuss infections of the nervous system. Although the brain and spinal cord are well protected, as we covered in the overview lecture, by the skull, the vertebral column, the meninges, and the BBB, microorganisms can still invade the central nervous system and cause life-threatening diseases. They can enter the CNS through the bloodstream, spread directly from nearby infections such as sinus or ear infections, or travel along the peripheral nervous, such as rabies. Now, once these microorganisms reach the brain or spinal cord, the body's inflammatory response often causes as much damage as the infection itself. Now, inflammation leads to swelling, increased ICP, reduced blood flow, and impaired nerve function. We're going to focus on 3 common CNS infections: meningitis, brain abscesses, and encephalitis. Although they all involve infection, they affect different structures and therefore present differently. So let's begin with meningitis, which is inflammation of the meninges surrounding the brain and the spinal cord. Bacterial meningitis is a medical emergency because bacteria spread rapidly through the CSF. As the inflammation develops, the CSF fluid circulation becomes impaired. ICP rises and the brain begins to swell. Patients typically present with fever, headache, photophobia, nausea, vomiting, and nuchal rigidity, basically stiffness of the neck. Now, two classic physical exam findings are Kernig's sign and Brodzinski's sign, both of which indicate meningeal irritation. Diagnosis is confirmed with a lumbar puncture, cloudy CSF with elevated white blood cells count is strongly suggestive of bacterial infection. Treatment includes immediate IV antibiotics, corticosteroids to reduce inflammation. And remember, treatment should begin as quickly as possible because delaying antibiotics significantly increases mortality. Next is brain abscess. Unlike meningitis, a brain abscess is a localized collection of pus within the brain tissue. It often develops after a sinus infection, ear infections, dental infections, or head trauma. Patients usually develop gradual worsening headaches, fever, focal neurological deficits, and signs of increasing ICP. And the treatment requires surgical drainage along with prolonged IV antibiotics. Finally, encephalitis. This is an inflammation of brain tissue itself and is most commonly caused by viruses such as herpes simplex or West Nile virus. Unlike meningitis, encephalitis often affects cognition. Patients may present with confusion, lethargy, seizures, personality changes, fever, and altered mental status. Supportive care is the mainstay of treatment, although antiviral medications such as acyclovir are effective for herpes encephalitis. This slide highlights the several additional infections that can happen with the nervous system. Rabies is almost always fatal once symptoms develop after an infective animal bite. The virus travels along the peripheral nerves towards the brain. Patients develop anxiety, agitation, difficulty swallowing, hydrophobia, seizures, and eventually respiratory failure. Fortunately, prompt vaccination after exposure can prevent disease. Tetanus or lockjaw is caused by toxins produced by the Clostridium tetani virus. Rather than infecting the brain directly, the toxin blocks inhibitory neurons, leading to severe muscle spasms, jaw rigidity, difficulty swallowing. Vaccination, the tetanus vaccine, remains the best prevention. Poliomyelitis selectively destroys motor neurons within the spinal cord, producing flaccid paralysis while leaving sensation intact. Although polio has become rare due to vaccination, it remains an important historical example of viral damage to motor neurons. Then we have herpes zoster, or shingles. This occurs when dormant varicella-zoster virus reactivates years after chickenpox. Patients develop a painful, blistering rash that follows a single dermatome because the virus reactivates within a sensory nerve ganglion. Finally, we have GBS, Guillain-Barré syndrome. This is actually an autoimmune disorder that often follows a viral illness. The immune system attacks peripheral myelin, producing a rapidly ascending muscle weakness that may eventually affect breathing. Fortunately, most patients gradually recover with treatments such as plasmapheresis or IV immunoglobulins. Traumatic brain injuries represent another major cause of neurological disability. Unlike many neurological disorders that develop gradually, trauma produces immediate damage followed by a cascade of secondary injury. The severity of neurological impairment depends not only on the force of the injury, but also on the location of the damage. A small injury involving the brainstem can be life-threatening, while a much larger injury elsewhere can produce pure deficits. So when caring for trauma patients, remember that preventing secondary injury is just as important as treating the initial injury. Brain injuries are divided into primary and secondary injuries. Primary injuries occur at the moment of impact and include skull fractures, brain contusions, lacerations, diffusal axonal injury caused by rotational forces. Now, one classic example is a acute contracute injury, where the brain strikes the inside of the skull at the site of the impact and then rebounds to strike the opposite side. Basically, it strikes one side, then hits the other side. Now, secondary injury develops over the next several hours or days. Swelling, bleeding, inflammation, and cerebral edema increase ICP and reduce blood flow, and this causes additional neuronal death. Patients will present with headaches, confusion, memory loss, nausea, vomiting, seizures, unequal pupils, or decreased consciousness. Vascular skull fractures may produce bleeding from the ears or leakage of the CSF from the nose or ears. Diagnosis relies primarily on CT scans because they quickly identify bleeding and skull fractures. Now, treatment focuses on preventing secondary injury by maintaining adequate oxygen, controlling ICP, preventing infection, and surgically removing hematomas when needed. Now, one important nursing priority is performing frequent neurological assessments to detect any decline in the level of consciousness, which may indicate worsening ICP. Now, spinal cord injuries occur when trauma damages the spinal cord through compression, stretching, complete transection. Immediately after injury, patients enter a phase called spinal shock. During spinal shock, all motor, sensory, and reflex activity below the injury is temporarily lost. Patients develop flaccid paralysis and absent reflexes. Now, as the swelling increases, as the swelling decreases, reflexes gradually will return. Unfortunately, because communication from the brain has been interrupted, these reflexes often become exaggerated, resulting in spastic paralysis and hyperreflexia. Now, the level of injury determines the patient's deficits. A cervical spinal cord injury causes tetraplegia, affecting all four extremities. A thoracic or lumbar injury typically results in paraplegia, affecting only the lower extremities. Now, one life-threatening complication is autonomic dysreflexia. This occurs when patients with injuries above get injuries above T6. A simple stimulus such as like a full bladder or bowel triggers an exaggerated sympathetic response. They basically cause severe hypertension, a headache, flushing above the injury, and bradycardia. So this is an exaggerated sympathetic response, right? So this is a medical emergency because it can lead to stroke or seizures. Immediate treatment includes sitting the patient upright, removing the triggering stimulus, and lowering blood pressure if necessary. An example of this is when patients who are, have neurological disorders when they have urinary retention. So when the bladder is overfilled, this can trigger autonomic dysreflexia, and the patient's blood pressure will skyrocket. And just emptying the bladder, can help with the problem because you're basically removing the triggering stimulus. Now, management of the spinal cord injuries begins with immediate spinal immobilization to prevent further damage. Surgery may be needed to stabilize the spine, followed by intensive rehabilitation involving physical therapy, occupational therapy, and psychological support. Although neurons within the spinal cord have very limited regenerative ability, rehabilitation really helps patients maximize their independence and their quality of life. Now, one concept ties all of these disorders together. The initial injury is often only the beginning, right? It's not the end, it's the beginning, where the cause of is infection, trauma, bleeding, inflammation, increased ICP, frequently produced by additional neurological damage. Recognizing and treating these secondary processes early is one of the most important goals in neurological care. Now let's shift our focus to congenital neurological disorders. Now, these are disorders that are present at birth and they result from abnormal development of the brain, spinal cord, or surrounding structures during fetal development. Some congenital neurologic disorders are caused by genetic abnormalities, while others are related to environmental factors during pregnancies, maternal infections, nutritional deficiencies, or complications during fetal development. Now, over here, and we're going to focus on just hydrocephalus, spina bifida, and cerebral palsy. Now, although these conditions differ in the causes, they all interfere with the normal nervous system development and can have lifelong effects on movement, sensation, cognition, independence. Early diagnosis and treatment play an important role in improving long-term outcomes. Here is a cheat sheet on three of the, disorders that, I wanted to cover. Please print this out and use this as a reference. I'm not going to go into detail with these because this is a pediatric topic, but you can use this as a reference. Now let's discuss seizure disorders, also known as, epilepsy, right? A seizure is a result of a sudden uncontrolled electrical activity within the brain. Normally, neurons communicate through carefully regulated electrical impulses. During a seizure, groups of neurons begin firing rapidly and simultaneously, disrupting normal brain function. Depending on where this abnormal electrical activity begins and how far it spreads, seizures can affect movement, sensation, consciousness, behavior, or all of these functions. Now, first of all, it's important to remember that not every seizure means a person has epilepsy. A seizure can also occur because of fever, hypoglycemia, electrolyte imbalances, head trauma, infections, alcohol withdrawal, or drug toxicity. For example, when a patient is hypoglycemic, they will start having seizures, right? But that doesn't mean they have epilepsy. Now, epilepsy is diagnosed when a person experiences recurrent, unprovoked seizures, right? Without any triggers, they're just having seizures. Now, during a seizure, the brain's demand for oxygen and glucose increases dramatically. If seizures continue for an extended period of time, neurons become deprived of oxygen. Glucose stores are depleted and permanent brain injury can occur. Now, many patients also have individual seizure triggers. These may include sleep deprivation, emotional stress, flashing lights, illness, alcohol withdrawal, or missed doses of anticonvulsant medications. So identifying and avoiding these triggers is important, in seizure management. Here is a cheat sheet for the different categories of seizures. Focal, they can be classified in two major categories, focal or partial seizures and generalized seizures. Focal seizures begin in one specific area of the brain. In a simple focal seizure, the patient remains conscious. Symptoms depend on the area involved and could include muscle twitching, tingling, visual changes, or unusual sensations. In a complex focal seizure, consciousness becomes impaired. Patients would be staring blankly, perform repetitive movements such as lip smacking or picking at clothing, and then they have no memory of it, right? And so generalized seizures, they involve both cerebral hemispheres from the beginning and always involve loss of consciousness. Remember, generalized seizures, loss of consciousness. One example is an absence seizure, formerly called petit mal seizures. These are brief episodes, usually lasting only a few seconds, during which the patient suddenly stops what they're doing and stares into space before quickly returning to normal. These are most common in children. And these are things that, absence seizure is very difficult to detect. So it's important to, educate parents to notice these things. The most recognizable, seizure is a tonic-clonic seizure, formerly known as grand mal seizure. Many patients experience a prodrome several hours before the seizure. They're feeling irritable or anxious. Some also experience an aura, which is an early warning sign, sensation such as a strange smell, flashing lights, or unusual taste. Some patients actually know what, their aura is, what will start their seizure, and they'll warn you. The seizure begins with a tonic phase, where muscles suddenly become rigid and the patient loses consciousness, often falling to the ground. This is followed by a clonic phase characterized by rhythmic jerking of the extremities. During this phase, patients may bite their tongue, lose bladder control, or develop frothy saliva. After the seizure after the seizure ends, then we come to the postidal phase. Patients are often confused, extremely fatigued, have a headache, and frequently fall into a deep sleep. This recovery period can last from several minutes to several hours. Now, diagnosing epilepsy begins with obtaining a detailed history from both the patient and anyone who witnessed the seizure. The most important diagnostic test is the EEG, which records the brain's electrical activity and helps identify seizure patterns. MRI or CT scans could also be performed to look for structural causes such as tumors, previous strokes, or scar tissue. Treatment focuses on first on correcting any underlying cause. Patients with epilepsy are usually treated with anticonvulsant medications that help stabilize neuronal membranes and reduce abnormal electrical activities. Examples of these medications include phenytoin, levetiracetam or Keppra, valproic acid, and phenobarbital, depending on the type of seizures. Patients should never stop anticonvulsant medications abruptly because doing so can trigger severe seizures. That's why we need to educate our patients. They should take their medications consistently, avoid known triggers, get adequate sleep, follow safety precautions if seizures are not well controlled. One of the most important seizure emergency is status epilepticus. Status epilepticus occurs when seizures last longer than 5 minutes or when repeated seizures occur without the patient regaining consciousness between episodes. This is a medical emergency because prolonged seizure activity will basically deprive the brain of oxygen and glucose that it needs, leading to acidosis, permanent brain damage, respiratory failure, and even death if it's not treated quickly. Emergency treatment focuses on first airway breathing circulation. Patients receive supplemental oxygenation. We get an IV access in them. Glucose if hypoglycemia is suspected. Medications such as lorazepam or diazepam because these benzos will help stop the seizure, followed by longer acting anticonvulsants to prevent recurrence. As a nurse, future nurse, it's equally important to know that what not to do during a seizure. Do not restrain the patient. Do not place anything in the patient's mouth. Contrary to popular belief, patients will not swallow their tongue. And attempting to insert an object to prevent this can cause dental injuries or airway obstruction. Instead, protect the patient's head, remove nearby objects that could cause injury, loosen restrictive clothing, and turn the patient onto their side once the seizure subsides to help maintain an open airway and reduce the risk of aspiration. After the seizure, assess the patient's neurological status, document the length and characteristics of the seizure, and monitor for complications during the postnatal period. When assessing a seizure, don't focus only on what happened during the event. Important information includes what happened, what was the patient doing before the seizure, was there an aura, how long did it last, what type of movements occurred, what was consciousness lost, what was the patient's condition during the postnatal period. These details will help help the provider determine the seizure's type and guide treatment. Finally, we're going to discuss chronic degenerative neurologic disorders. Unlike acute disorders such as stroke or trauma, these conditions develop gradually over months or years due to the progressive loss of neurons or supporting structures within the nervous system. Although each disorder affects different parts of the nervous system, they all share one common feature, the progressive loss of neurological function. Some disorders involve destruction of myelin, while others involve the loss of neurotransmitters, degeneration of motor neurons, autoimmune damage to the neuromuscular junction, or inherited degeneration of specific brain regions. So let's look at each disorder and identify what part of the nervous system is primarily affected. Let's start with multiple sclerosis, MS. This is an autoimmune disease in which the immune system attacks the myelin sheath, covering the neurons in the brain and spinal cord. As myelin is destroyed, nerve impulses travel more slowly or maybe even blocked altogether. Early in the disease, inflammation causes temporary symptoms that can often improve during periods of remission. Over time, repeated attacks leave scar tissue called plaques, resulting in permanent neurological deficits. Now, symptoms will vary depending on the nerves involved, but commonly include blurred or double vision, numbness, weakness, fatigue, poor coordination, tremors, or in bowel and bladder dysfunction. Diagnosis is based on clinical history. MRI findings showing multiple plaques, CSF analysis, and evoked potential studies are also used. Although there is no cure, medications such as interferons help reduce relapses, while corticosteroids will treat acute exacerbations. Physical and occupational therapy can help patients maintain mobility and level of independence. Parkinson's disease is very different from MS because the problem is not myelin. It is a progressive loss of dopamine-producing neurons within the substantia nigra of the basal ganglia. Without enough dopamine, there is an imbalance between excitatory and inhibitory signals controlling movement. This produces the classic symptoms of Parkinson's disease. Now, one way to remember these are using the acronym TRAP. T for tremor at rest, R for rigidity, A for akinesia or bradykinesia, meaning slow movement, or P for postural instability. Patients often develop a shuffling gait, stooped posture, decreased arm strength, a mask-like facial expression, soft monotone speech, difficulty swallowing as the disease progresses. Treatment focuses on replacing dopamine with levodopa, often combined with carbidopa, and using medications that prolong dopamine's effect. Physical, occupational, and speech therapy also help, patients maintain function. Now let's talk about ALS. It's also known as Lou Gehrig's disease. It's a progressive disorder that destroys both upper and lower motor neurons. Because motor neurons degenerate, patients gradually lose voluntary muscle function, while sensation, cognition, and eye movements remain largely intact. Patients typically begin with weakness in one hand or arm, muscle cramps, and fasciculations, basically visible muscle twitches. As the motor neurons are lost, weakness spreads to the legs, speech muscles, swallowing muscles, and eventually the respiratory muscles, causing respiratory failure. Unfortunately, there is currently no cure. Riluzole medication may slow the progression somewhat, but treatment focuses primarily on supportive care, respiratory management, nutrition, and maintaining a quality of life. Myasthenia gravis differs from the previous disorders because the problem is not with the brain or the spinal cord. Instead, it occurs at the neuromuscular junction. In this autoimmune disease, antibodies destroy acetylcholine receptors on the skeletal muscle, preventing normal communication between nerves and muscles. The hallmark feature is muscle weakness that worsens with activity and improves with rest. Patients often first notice drooping eyelids, double vision, difficulty chewing, swallowing, speaking, or holding their head upright. Diagnosis includes antibody testing, electromyography, and a tensilin test. Treatment includes anticholinesterase, medications such as pyridostigmine, immunosuppressive therapy, plasmapheresis, and sometimes even removal of the thymus gland. Finally, Huntington's disease is an inherited neurodegenerative disorder caused by a mutation of chromosome 4. Unlike previous disorders, Huntington's disease follows an autosomal dominant inheritance pattern, meaning each child of an affected parent has a 50% chance of inheriting the disease. The disease primarily affects the basal ganglia and frontal cortex, leading to progressive cognitive decline, psychiatric changes, and involuntary coriform movements, which are rapid, jerky, dance-like movements. Early symptoms often include personality changes, depression, irritability, difficulty concentrating. As the disease progresses, patients develop worsening movement disorders, dementia, and complete dependence on caregivers. Diagnosis is confirmed through genetic testing. Although there is no cure, medications such as tetrabenazine help reduce chorea, while supportive therapies help maximize quality of life. One of the most important principles in neurology is that structure determines function. So the symptoms a patient experiences depend on which part of the nervous system is affected. Now, acute disorders such as brain tumors, stroke, infections, and trauma often require immediate, interventions because the earlier we, intervene, permanent damage can be prevented. And genital disorders such as hydrocephalus, spina bifida, and cerebral palsy affect the nervous system development, and these require lifelong management to maximize function and independence. Seizure disorders result from abnormal electrical activity in the brain, so prompt recognition and treatment are essential to prevent complications such as status epilepticus. Finally, chronic degenerative disorders involve progressive damage to different parts of the nervous system. For example, MS damages myelin. Parkinson's results from dopamine deficiency. ALS destroys motor neurons. Myasthenia gravis affects acetylcholine receptors at the neuromuscular junction. Huntington's disease is an inherited disorder causing degeneration of the basal ganglia and cerebral cortex. So rather than memorizing long lists of symptoms, instead try to understand what structure is damaged and how the damage explains the patient's clinical presentation. This will help you, understand and recognize these disorders and also help you with the NCLEX if you're in nursing school. So thank you everyone. I hope you enjoyed this lecture and have a great day.